right. Well, welcome everybody. It looks like we have quite a few attendees. Thank you all for joining us today. This session is called Crisis Care Continuum, the Tipping Point, with Charles Browning and Joy Brunson. Joy, would you mind pronouncing that? I always slip it up.
In Subuga.
Thank you very much. We want to remind everybody that your cameras and your microphones are up because this is being recorded. Please, if you have any questions for the presenters today, put it in your chat box. If you have any technical issues, put it in your chat box and our CVET support will help you with that. At this time, we'd like to get started. Joy, would you advance?
Sure.
The views, opinions, and content expressed in this presentation do not necessarily reflect those of our funder, the California Department of Healthcare Services, or our CARE TA Center partner agencies listed below. In the case of any security issues that may occur, this session will immediately end and will not resume. A separate email will be sent to all participants with further instructions. Thank you. You are welcome to use the chat box to message the speakers. You may send messages that are viewable to the whole meeting room. Please use I statements in the chat and avoid making comments that are stigmatizing or otherwise injurious towards others. If you do not want to engage in the chat feature, you can minimize the chat box. You can also select speaker view to enlarge the video of the speaker and remove most participant videos from view. If you experience tech challenges, a CVET tech host is available to support. You may message them in the chat box. Remember, please, to be kind and courteous. Listen attentively and with an open mind. Share the space. Expect and accept a lack of closure. We won't get to everything, but we'll get to as much as possible. If informed that our comment or behavior is stigmatizing or injurious, we will acknowledge and apologize. There's also some crisis resources in case anybody would like them. So once again, this is being recorded and we'd like to begin the session now. Dr. Browning, Joy.
Thank you. Chuck, do you want to introduce yourself?
You know, I always want you to drive the,
Yeah.
the car.
Yes. Hi, everyone. I'm Joy Brunson in Subuga, and I'm the Vice President of the Southeast for RI International. I oversee North Carolina and Louisiana as a part of my region. I've been with RI for 7.5 years now, mainly focused on crisis continuum and access for everyone in the states that we operate in, and then also focused on MAT treatment and diversity, equity, and inclusion as well. Chuck?
Thanks, Joy. So I'm Chuck Browning. I'm the Chief Medical Officer at RI International. I'm also the Medical Director of Behavioral Health Link in Georgia, which does crisis call line for the entire state of Georgia, as well as mobile support teams for 2/3 of the state. So, I've been working with RI since 2009, actually in one of our crisis receiving centers in a rural area of North Carolina, starting back in 2009 then, and had the pleasure of being able to grow with the company as we work and talk about crisis services and hopefully be able to share some of that with you today. And I have special interest in the fusion model and connectivity of taking the best parts of the biomedical hospital model of care and combine it with peer support and recovery oriented focus of approach.
Thanks. So this is a 3-part series, and we are in the second workshop called The Tipping Point. Across the 3 sessions, our objectives are to provide data and real-world examples of research and context for the crisis system in the U.S. Attendees will be provided with information on the intersection of disparities and inequities in healthcare. And attendees will learn about the most up-to-date information on innovation and technology in the crisis continuum space. So this is our second workshop in this 3-part series, the Crisis Care Continuum. So we wanted to kind of recap just a little bit from our first presentation that was entitled A Crisis in the System. And so during that presentation, we really talked about how the system is set up now for behavioral health crisis for individuals who experience those challenges. When they call 911, they're engaged by the police and are taken to the emergency room or sometimes taken to jail. And we talked about how that impacts individuals that are trying to get care. And we also talked about the barriers that have been historically in the system and how the system has been set up in a way that hasn't been the most inclusive for the individuals that we are here to serve. And Chuck gave a very great metaphor. I don't know if you want to repeat that for this session as we get started.
For anybody that didn't mention, I'm not going to go through the entire details of the story, but it was a story about an obstetrician who figured out back in the 1800s that there was a problem of infection being passed in one group of people that were working with doctors versus the people who work with midwives, and figured out that the problem was that the doctors were doing autopsies of the people who had died of this infections during childbirth and then spreading it to healthy people during exams the following day after doing autopsies, because of back then they didn't understand germs. And he figured out that that was a big difference between the two groups and why death rates were much higher, and instituted a hand washing principle. And by adding in hand washing as an intervention, it made a huge difference and normalized those two groups out. And so we use that as a metaphor to talk about the concept that when you have a system and things aren't working and there are barriers for different groups of people, don't settle for status quo, look for interventions that can make an impact and on that. And then we also talked about the metaphor that even though he discovered that and it had a big impact, it didn't take on right away. It took time and decades later before hand washing became a very preeminent, prominent thing that's now just commonplace in medical healthcare settings.
Thanks. So this is the current pathway for individuals that are experiencing a behavioral health crisis, again, leading to either a stay in the hospital or oftentimes leading to jail. So we discussed how the system was set up, some interventions that have been attempted before, because the gaps in the system were starting to be noticed. And so for this presentation, we're talking about the tipping point. We're talking about the last year. We're talking about some things that have been put in place that is changing that pathway. Things that are very regional, and that have not caught on across the country, but have the potentials to impact those gaps that we have identified as areas that we need improvement. And those gaps are access for all, individuals being responded to by behavioral health professionals and being served in behavioral health settings when they are in crisis. So this slide is showing that there are other options. So in Phoenix, Arizona, when someone calls 911 or it expresses that they need help or they have an interaction with the police, there is another alternative. It is not an automatic that they are then sent to the emergency rooms where the emergency rooms are not set up to serve them. There is another option that mobile crisis can go out to support someone, and also an option for law enforcement to take individuals directly to 24/7 crisis facilities that are there, open and ready to be able to work with individuals that are in a behavioral health crisis. So over the last years, we have seen a great difference that Chuck is going to talk about with just making that one change in the system.
Yes, Joyce. So through having, as we did a highlight back in the first part of what are the elements of crisis now, and it's having an equivalent of 911, which they have crisis call lines, then having an equivalent of EMS or paramedics, which is behavioral health mobile support teams coming out to see people, and then having an equivalent to the emergency department, which is crisis receiving centers. And so in Arizona, these crisis receiving centers are mandated to be no wrong door and to never say no to police and law enforcement when they drop somebody off. So what happens when you create that flow system is that there's different levels of care. People are not just funneled from either jail or emergency departments or waiting in EDs for hospital beds. And so there's more bandwidth and appropriate clinical fit care to need for different levels of care based on what people need in their crisis. And everyone gets access because, again, there is no wrong door. So some of the impacts that were studied in a study back in 2017 in just the Phoenix metro area, which is Maricopa County, it's a population of about 4 million. And they looked during that 1 year, what is the impact of having those pieces in place working and functioning correctly? So there was a 6 times better fit of crisis clinical fit need using a locus score, which is a level of care utilization system that helped look at that people did hit 6 times more likely to land in the correct lane of what level of care they would need. 37 FTEs of police officers in that 1 year of time that was saved, where those law enforcement could be engaged in public safety issues instead of managing behavioral health out in the community. This was a big one, 45 years of emergency department waiting time just from that 1 year by having those systems in place. So as most of you know, there's a huge challenge. And one of the answers historically has been in the years back that we just need more inpatient beds, which again furthers the chance of institutionalization. It's very costly. Most hospital bed situations end up people staying potentially longer than in this crisis now model. So it sometimes it misses that clinical care fit to need. But that's a huge impact when you have those different lanes and places for people to go that matches up with what they need. So there's a $37 million avoided costs and losses in hospitals because of that lack of time of people being in emergency departments, as well as an overall $260 million overall healthcare spend, which, by the way, is 2 times the amount it costs to run those crisis services. So the last impact piece is that while it's such a business case that makes sense, the benefit and the beauty of it is it really starts to have a chance to be a correction in the system that we've been talking about in part 1 that offers a priceless opportunity to create engagement, connection, and an actual behavioral health appropriate response for people in crisis, rather than some of the typical barriers and challenges that we have in our system now.
Absolutely. So with those changes that have already been put in place, now there are different options for individuals when they are in a behavioral health crisis, right? So now there are mobile teams that can go out and support crisis facilities that individuals can be served in by behavioral health professionals. And from those crisis facilities, if someone needed longer term care, then that could be a referral straight from that facility. But oftentimes we see the crisis facility has the ability to stabilize someone, to provide those supports, and then to be able to transition those individuals to their community resources, back to family members, to outpatient services, enhanced services, all of those things while staying in their current community. So what changes does that already make as far as impacting the system? As you have, or I talked about in the previous session, we were really looking at some of the barriers being that individuals, when they see law enforcement come to respond to a crisis, or if they are interacting with law enforcement, there are communities of color and individuals who are directly affected by this, by being taken to jail, to a hospital, being re-traumatized. All of these things can happen. And so when you're thinking about the impact of just that intervention that has already had an impact on the system, we are seeing individuals that are being served when they are in need in a facility in their community without law enforcement involvement. So when we're thinking of how do we move this forward, There's another gap that we can also start to address, and that is through not calling 911 at all, right?
So with 988 and the future hope of what it offers us, Joy, is a chance to have an intercept from that connection of 911, which would then bring out law enforcement out in the communities, but actually have an intercept so that people who call and learn, number one, it's an easy to learn number, 988, compared similar to 911, and it will be easy to remember than some of the 1-800 crisis lines that we have across the country now. So that's going to be one huge thing. But the second part is having that regional, statewide type approach to having trained people to take the call and coordinate with law enforcement and emergency medical services. It offers an opportunity to capture a vast majority of calls that we expect to come through. You know, we have almost a minimum conservative assessment of about 25 million of the 250 million calls that come through to 911 now across the country are related to behavioral health. And so those, along with calls that typically go to Lifeline and other state and local crisis call lines, make up probably an estimate of about 40 million calls that now can be on this different path, automatically avoiding ED visits, contact with law enforcement, and creating a new paradigm for future engagement and connection. If you weren't on part one other thing that is really important about Crisis Now to understand is that if a crisis line is functioning correctly, about anywhere from 75 to 90% of folks can be de-escalated and supported in the community on the phone with different types of services, as well as connected to follow-up. And then that small percentage that needs someone to come to them, mobile support teams then in the places where mobile support teams are working effectively are running somewhere between 70 to 80% of those calls, helping stabilize that person in the community, connecting them to safe follow-up. So then you have an even smaller percentage that comes to these crisis receiving centers. And in those receiving centers, about 70% of people that come into the 23-hour observation side, which would be equivalent to emergency room, also return to the emergency department. So as you can see, you're just continuing to funnel, finding the appropriate level of care for what people need, but making a big impact on not everyone that has in crisis ends up going to the ED, ends up having liability concerns by an ED medical staff who's worried about are they going to be safe on the street or not, and then puts them handcuffed to a gurney in the emergency room waiting for 5 days for a bed that's not open yet in a psychiatric inpatient unit. So there's a functionality of a flow management that this issue creates, but it's much more than that, as we're going to get into.
Yeah, and as you can see from the slide, if someone has a medical emergency and they call 988, there's still the pathway for them to be able to get the treatment that they need. If it's a public safety threat, there's still the option for police engagement. But if someone is in a behavioral health crisis, being able to create that pathway that does not include police, that does not include the hospital, but includes them being able to be served in the community that they're in a facility that is set up for them is really what we feel is the best care and best option. So we're going to go into a little bit about the 3 core services and how that translates, because oftentimes in different communities, as members of communities, professionals in the communities, we have different thoughts and ideas of how services are operated based on our experiences. And so we really want to make sure that we are giving a good explanation of what the services are, and that we are talking about services that are competent to serve anyone, anywhere, anytime, and are not there to screen out individuals based on presentation, based on maybe screening out modules or concerns or lists or anything like that, but are there to help individuals that are in a crisis.
So Joy, I guess this is a slide that shows some of the states that we're operating in. We're actually going to be this year in two more states that aren't mentioned here in terms of the places where we at RI run crisis receiving centers that follow that no wrong door approach and model, a lot paired with the type of treatment things that we're going to discuss later on, which we call the fusion model. And then finally, Georgia, again, is where our sister organization, Behavioral Health Link, is, that does crisis call lines for the whole state, as well as mobile support services for 2/3 of the state.
Absolutely.
I think the next slide talks a little bit, so we can talk about some of the details. So when you look at this Crisis Now three core services, we introduced them in part one, but we're going to talk a little bit more in depth about what they are and how they should work. There's basically equivalent for 911, an equivalent for paramedics or EMS, and an equivalent for the emergency department. This is all supported by technology that is in existence right now that helps coordinate the valve management and the kind of air traffic control dynamic of making sure that when someone is in crisis, that technologically there is a way to, just like you watch a plane on a radar screen from the time it takes off till it lands, and if there's any kind of trouble, the team can completely zero in on that plane and support things that are going on and what's happening around it. This technology allows that same type of thing to happen when people are in these different levels of this system, when it's used correctly. And then the final piece that's layered over top of all of it, Crisis Now is the foundation for the premise of SAMHSA's recent release of the National Toolkit for behavioral crisis care. And one of the things, it outlays these three core services, but then the fourth piece that's oftentimes not discussed or not promoted enough, I think, and it's one of my passions is to share that, is the essential care practices that align with all three of these lines of service. And that includes significant use of peer support, a recovery-oriented approach, trauma-informed care, zero suicide or safer suicide principles embedded into what you do, coordination with law enforcement and medical services, and safety and security for staffing. And so you layer those three things, those elements of the care principles into these three layers, needs to be present in all. So there should be peer support involved in crisis call lines, in crisis mobile teams, and at crisis receiving centers, and all of those care principles. One of the things we're talking about today is about disparities in racial issues in all of these three lanes. This is a problem in our system. And so part of trauma-informed care is making sure that we are being inclusive to diversity of all of our populations in the community that we're serving. And we're going to talk some about the impact of these systems on that today, as well as in our part three, some future things to consider and be thinking about. So Crisis Call Center Hub is equivalent to 911. It is a call line that just operates 24/7, that the goal is to be able to answer calls like a 911 service, hopefully de-escalate and support that person there. But if they need a higher level of care, then activating mobile support. As this moves forward 988, there's going to need to be coordination with law enforcement and emergency medical services, because sometimes when people call, they have an emergency medical situation or an imminent public safety risk. But when the system works correctly, that's a very small minority of the calls that you actually need to have law enforcement go out and be present. And in fact, I think it's in the Arizona numbers where we've tracked that. They have a average response of about 3% of calls that require law enforcement to go out with mobile support for safety issues. Mobile support teams, there's lots of variations of those around the country, but the one promoted by SAMHSA's National Toolkit involves the use of a licensed clinician and a peer support together as a two-person team, going out everywhere, not just showing up at an emergency department, but actually going out in the community, whether it's someone that's homeless or someone at a home, going to meet them, help support and connect them if they can to stay in the community with the appropriate follow-up, but if not, then helping them to get placed and connected to a place to go. And then the crisis receiving centers would be a freestanding unit. And there's different variations of these across the country already, but the core purpose, if you don't have one, it's like a firehouse model. If you don't have an emergency room equivalent that can accept everyone, then there's always going to be a group of people that get excluded and don't get care and don't get access to that service. And then those are the people who will end up going to jail, staying on the street because they get refused access to care, or stuck in an emergency room for 5 or 6 days waiting to get connected to an inpatient bed. So I guess I'll talk a little bit. So at RI International, we use this tool, what we call the RI way, of these 4 keys, as like a ladder of guidance to help us be able to have the infrastructure to support someone that's 250 pounds that might be intoxicated with methamphetamine and randomly punching at people because they're challenged with feeling that people are out to get them. Their frustration tolerance is very limited. And those are folks that oftentimes end up in seclusion and restraint at an emergency department or end up into challenges with law enforcement out on the street that oftentimes, don't get the care that is appropriate for what, we know works and helps support people during those crises. But at the same time, we want a place where staff and that person can be safe, so that if that was a family member of you, that you would want them to be in a place that could be safe and support them. But at the same time, it'd be a place that you would want your loved one or yourself to be if you were in crisis. And so we focus on these 4 keys. It's a kind of a copycat off of Disney's 4 keys that they use for their staff. And Disney has 4 keys of safety, courtesy, show, and efficiency. And for us, we use this guide for our staff members to be able to think in their head as they're working with people, kind of a rung of ladders of appropriate things. So number 1, safety first. Is this safe? The customer that we're serving, the guest that we're serving, they probably aren't aware of safety things unless something bad were to happen. They're going to care more about the second most powerful rung for us, which is engaged or engagement, which means, the enemy of engagement is avoidance. So when you're in a crisis receiving center, not having eye contact, not saying hey to someone, not connecting with them, not offering a caring attitude or a caring smile. And when people work in crisis emergency situations, it's easy for that to die down. So that's our second most number 1 after safety, most important principle is making sure that we are connected and engaged out on the floor working with people. The third is peer power, which is a set of principles of peer power practices that are not just about the peer support in our unit that do that, but all of our staff, whether you're a provider, a nurse, a licensed clinician, that there's certain peer power practices that include things like trauma-informed care, a strengths-based approach that's not just focused on medication and illness, but offers other alternatives. No force first. A whole health fitness approach to everything, that looking at the whole person's health, including their family and their community supports. And then the biggest one in this, and this is one of the things that I think is really important in terms of racial disparities in healthcare, is having a connection of collaborative, so that a person feels like they're being treated as a human being and that you're doing things with them and engage with what works for them and letting them have a voice in saying, this is what helps me or doesn't help. Because again, one of the things that, at least in our discussions and work on this within our company of how can we do that better, is that something that is so common that if we don't create a trauma-informed care approach to help people feel engaged and supported, that can be there. And then performance is last. It's not that it's not important, but you don't sacrifice engagement or how the way you treat people over efficiencies. Efficiencies matter, and you have to have workflows, but if they're so rigid that you have to make a person feel like they're a widget in a factory as they're going through a process of being evaluated, it takes away all of the care and the crisis de-escalation aspect about it. And we have found that if you focus on those other 3 things first, and still give guidelines of how to help support efficiencies, you still have, you still are successful in that. And it's an important piece, but it doesn't overrank those others. And so we call that the RI way.
So as we're getting into talking about the crisis receiving centers and the mobile response teams and the call centers and the best practices, we want to make sure that we're not forgetting the prevention and the aftercare pieces, because that's a part of overall care. So one of the things that we do is that we have a campus of connection. And as you can see, there are services that are available for urgent care, for immediate access. When you walk in, you're able to be served, get that support. Also higher level services to support detox and stabilization, mental health stabilization, but also looking at those step down services like respite, employment care, primary care, all of those things that we really need to look at whole health. And we talked a little bit in our last workshop about making sure that we're addressing whole health, the whole person, and not just one or 2 pieces when someone is in crisis. So even if one facility or one area doesn't have all of these things right there in place, having those really strong connections to that an individual can really have those resources available to them so that they are able to really address all of their needs, from mental health, substance use, basic needs, housing, employment, all of those things, so that they can return to being thriving in their communities. And not to forget the importance of family. Oftentimes when someone is in a crisis, they are cut off from their supports. They might be transitioned out of their neighborhoods, out of their communities, and not have access to those individuals that have been there for them. So being able to have that family support available and ready, and make sure family can be involved, is a really big part of services. So Chuck, what about fusion? Why is fusion important?
So the fusion model is a description or a name that we came up with at RI to describe this balancing act of two things. One is, how can you carry out no wrong door and have the medical staffing, the safety for your staff to be able to support that person I described, that 250-pound ex-military guy that comes in intoxicated on methamphetamine and is really aggressive. And at the same time, it still be a place you would want your loved one or family one to be, where people are treated warmly and it's a welcoming environment. And that's one of our definitions. And the answer is, it's really, really hard. We don't have that figured out yet. There's always this pendulum balance between safety and control of minimizing risks with comfort and choice. And it's a tension act constantly in figuring out how to balance that out. And that's where we use the term fusion, because fusion is actually like trying to put two parts of an atom together to fuse. It can generate the most amazing power and energy. It's what drives our sun and the stars. However, it takes an unbelievable amount of heat and pressure to make that work, and getting those things to come together. We have not figured out how to do that on Earth yet, even though there's been millions of dollars of study and work on how to do that. Likewise, sometimes it's really hard to pull those elements together. And one of the things at RI that we're really proud of is working together to pull in the best parts of the medical model and the biomedical world, and the best parts of peer support and peer recovery and recovery focus, and how to fuse those things together in a multi-purpose team. So I think there was a question in the chat that asked, how do you staff these no wrong door units? We'll answer that and talk about that. But the answer is, it's not always an easy balance to deal with the tensions about the ways that different parts of this model think. And it takes a culture and being hardwired into the leadership and into the group of what you do, how you hire, how you train, how you work on a daily basis to follow that, to be successful in getting that blend. And like I said, I don't feel like we have that figured out, but I really want to promote it because I think it's an element that should be present in all of behavioral health and all of healthcare in general. So that's where this is just that slide that talks about where can crisis go, is we want to look towards being able to have these options where everyone has access and doesn't run into barriers that we showed and talked about in the last part one, but that when they come in, they get this recovery oriented approach that actually de-escalates their crisis, either helps them start on a path of recovery if they've never been there before, or get back onto their path of recovery. And then it's done in a really caring, genuine, caring, compassionate way, and not something where a person feels like they're a piece of a process.
So this is just an example of one of the facilities that I oversee, actually, and just to give an example of what that would look like and feel like, because the environment is just as important as staff. Is just as important as any other interventions that we do, to make sure someone feels comfortable and welcomed, and that we're there to serve them. So this is actually one of our entry points into the receiving center, and that is what we call our retreat. And in this is where all of our assessments happen, and psychiatric evaluations, peer support. We're peer first and peer last. And also we have nursing assessments and everything for that evaluation and observation over that first 23 hours. But it is done in an environment that supports community and connection and engagement with individuals that are there and with our staff as well, and a healing space for individuals to be able to be open to the recovery process.
And Joy, I was going to I'm glad you put up this slide. This is actual data that talks about what's happened, and it helps share a little bit of this tension of what we've been through at RI. This is one of our flagship centers in Arizona, in the Phoenix area, in our Peoria site. And back in 2014, we weren't completely no wrong door. We were accepting 57% of people coming in dropped off by law enforcement. So I want to explain something. We've been talking about this model and not having law enforcement involved. And so that's one of the things that the state of Arizona still has to figure out, is that they have created a system where it's really easy for law enforcement to either, if they have someone that's on involuntary petition, or if someone is out in the street that they encounter that looks like they're having behavioral health issues, they can ask them if they would like to go to one of these crisis receiving centers, and law enforcement doesn't have to make a decision. They know they can come and drop somebody off and be in and out in 5 minutes. So it does increase access, but when we look at the future, we're going to talk about, are there ways to further even improve that? But it is a measurement of whether or not you're truly being no wrong door in Arizona, is the number of and percentage of law enforcement drop-offs that you can facilitate and manage. And so back in 2014, we were at threat of not being able to provide crisis services in Peoria any longer, because even though we were taking 57%, we were still at times saying, no, this person's too acute, this person's too intoxicated, and if you say no to law enforcement in Arizona nowadays, and the way that system is set up, you will not operate crisis centers there in that service. And so as you can see over the years, our numbers of law enforcement went unbelievably higher, and we have worked through and still are working through that pendulum of how to do that, and then still capture that recovery oriented focus with that. But as of this year, I think we're up to 25,000 straight law enforcement drop-offs where we never said no. And our current recent average of time that law enforcement spends in a drop-off where they drop someone off and leave is 2.5 minutes in Peoria. When I talked to Matt yesterday, Joy, that was their number. So really fast, so they're back out on the streets with doing public safety. And what that means, if you look at that, look at the number of thousands of more people now that, instead of being left out in the community or going to jail or being taken to an emergency room, are getting behavioral health specific services. So it just tells you a little bit about the impact of what you can do when you create that lane.
Yeah, and as you saw my face with the 2.5 minutes, we have this kind of healthy tension between facilities on providing the best care for individuals that come, wanting to serve as many individuals as we can, and a little bit of rivalry around that transport time for officers. I think in my region, we're at about 3.8. So it looks like we've got some work to do. So when we're looking at the campus model, we're looking at no wrong door. We wanted to put up this slide as well to show, as we are building out facilities and increasing impact and footprint, we are continuing to perfect the craft. So this title of this presentation specifically is the tipping point. And so this is one of the facilities that was built over the last year during this pandemic process. And as communities are really coming together and states are coming together and looking to fill those gaps and making sure that everyone is being cared for anytime that they're in crisis. This is an example of one from Louisiana, where their process now includes 4 units in one location that has different levels of care. One access point where individuals can come in anytime, law enforcement involvement as well. There's a police entrance for when police encounter individuals. But then we're also including different levels of services in that one area. Again, looking at the whole person. When someone presents, they should be able to get the care that they need when they need it. And then looking to be able to, again, respond into the community and be able to have behavioral health professionals with a behavioral health crisis. And then follow up. That aftercare piece is so important. Being able to have discharge planning, community resources, and to be able to follow individuals into the community for up to 45 days after they're able to discharge. And again, just being able to follow that individual, support that individual when they're in crisis, provide the services, and then ensure that they are warmly connected to their next level of care, and that they have that continued support from individuals that have been with them during their crisis while they're following them into the community, while they're getting connected to their social supports, their behavioral health supports, all those resources that they will need to continue to be stable in the community.
And this is just an example of some of the different sites that RI runs in different parts of the country, and you can get an example of that open environment. So again, dealing with folks who a lot of times at a particular ED or hospitals, inpatient hospital unit, the staff will be behind plexiglass, and it might look pretty drab with hallways. You see big open spaces, windows, light, no plexiglass, so the staff is connected. Because again, remember our second key is engagement. So it's an environment that supports connection and support with that. But then you have training for staff of knowing how to work on safety things if someone is imminently trying to harm themselves or harm someone else and things of that nature. And this last two slides, because it's time to get to questions, I talked about how we were really a boutique service in 2014 and that we weren't serving everyone, and we had reasons to say no. And one of the things that we are seeing and promoting and talking about is, as we build this system, and you're building a system in your community and thinking about what does your community want and need, if you screen out, you're opening the door for implicit bias and other factors to create spotlights and decrease access to other groups and other demographics, either through the system just creating barriers, or by creating an unengaging, not helpful environment that gets out in the community that's not safe or not helpful for you to go get access that service.
Mm-hmm.
And so, you want to talk about this, Joy?
Sure. So over the last year, RI has been very intentional about looking at who we're serving, who we are staffing our facilities with, what type of services we are providing, and are they culturally appropriate? Are they welcoming to everyone? And kind of what impact are we creating? And so this slide, through our data, we specifically so far have looked at the African American community in every location that we are serving. And what you see is that on the darker blue column is the percentage of African Americans specifically in that community. So we are looking again specifically at the communities that the crisis facility is in. And then on the light blue column, you're looking at what percentage of African Americans are we serving out of everyone that has presented to the crisis facility or has been referred. And so what you're looking at is that we're serving more African Americans in our crisis facilities than the percentage of African Americans in the community. And that is a really big deal to us, because that means that we are impacting communities in a way that is most meaningful for them. And this is just the start of the data that we're starting to pull and track. Like I said, we are now looking at staffing. When you go into the community, the individuals that know the ins and outs, the culture, the nuances, the family ties, the important pieces are from those communities. And so looking at staffing, does our staffing reflect the community? And then also moving out to other demographics and looking to see what impact we're having. So I know we're right at the end, so this is gonna have to be a little bit fast. Chuck, do you want to talk about this slide as a precursor to our next presentation?
What happens as a tipping point when, and it's the title of this is when you get to the top of the tipping point and then things start to go downhill, then you pick up momentum really quickly. And right now it truly is an unprecedented time in our country between the impacts of things with the COVID pandemic, social justice movements, the motivation by the public will to change the dynamics between police, law enforcement, and mental health intersection. Cost saving issues. A lot has created this tidal wave of movement and momentum to be able to move towards an idea of shaping a new system that has opportunity to be a better system that doesn't have those barriers. So we have the opportunity to instill that hand washing metaphor into that. And it's going to be really important to look at that and to look at your role in it and what you want to do in that community. And that's what part 3 is going to be all about, is talking about design, future. What are some of the options? What are some of the things that are being forecasted now? As you can see on the outside of this wave, though, there's a lot of support in terms of funding through these different grants and set-asides and CARES Act and American Rescue Plan that offers funding at an unprecedented level to be able to support the change and growth in this. So I think we're open for questions now.
Well, thank you, Joy, and thank you, Chuck. That was a wonderful presentation. RI looks like a wonderful place to visit and to work. I'll have to get there sometime. We have one question, Chuck, that you touched on briefly, but I'd like to read it again in case you'd like to expand on it. Kelly asked, for the No Wrong Doors Center, how are these centers typically staffed and licensed to ensure individuals have the necessary resources to assist them medically, psychiatrically, spiritually, etc.?
So that's a great question. And I'll go into a little bit more detail since that's one of the questions to help be able to share that. So what I would say is that, our recommendation when you look at SAMHSA's national guidelines, it is a combination of, it's a multidisciplinary team that includes the presence of psychiatric providers. So it can be, nurse practitioners, psychiatrists, physician's assistants that have specialty in psychiatric, licensed clinicians, peer support, nursing. 24/7 nursing is really important because this system does not send everybody through the emergency department first to get medical clearance before you come back. It's really important that the site has some medical infrastructure and a triage risk assessment process when people come in, so that we can figure out if there is a really dangerous or acute thing that puts that person at risk being at a center in the, while they're there during their crisis, that will put them at risk if they're not. And we track over the decade plus time of doing this that we average about 4% of people that present actually need to go to an emergency department for a particular medical issue. So it would be things like chest pain, all of a sudden shortness of breath, signs of a stroke, different major risk things. But all the centers have a basic infirmary level of care with the ability to manage blood pressure, diabetes type things, in basic antibiotics for certain infections, basic wound care if needed, but they're not doing heavy duty amounts of that. So you have to have some nursing, you have to have some primary care knowledge and support within your providers and your nursing to be able to support that. But the second part of that question is, how do you meet the other needs? And that's the part that I am is so important to me in relation to this fusion model, is that everyone on the staff is not just peer support, that lead advocacy for other holistic and whole health ways of approaching your recovery. The old, mode in the medical model was, if you had depression and suicidality, you come into an inpatient unit, they start you on antidepressants, and you may do some therapy and work like that. I'm not saying that never happens, but that the diagnosis and the treatment is the main focus. Whereas in a recovery-oriented approach and in a whole health approach, you're looking at the person's strengths. What's their meaning and purpose in life, and what's their community and family supports, and how does that all work together to help them have hope and empowerment about moving forward in their crisis. And we find that that's as powerful or more powerful than that other piece. You have to have that piece sometimes. For example, if someone comes in and they're at very high risk for alcohol withdrawal, which could be fatal if not treated correctly, you have to have the expertise to do that. But at the same time, you want the expertise of everyone being able to help approach that person in that way to be able to support them in their recovery path and moving forward. And that includes spiritual realm too, as you asked in that question. Joy, do you have any thoughts? I know I rambled on forever on that answer.
I think the only thing that I will add to all of that is going beyond what Chuck is talking about also includes the community. So having community involvement, community groups come in to support the different aspects of someone's whole person self. So whether that's networking groups, whether that's exercising groups, whether that's spiritual groups, all of those having the ability to have open access for the community to be able to support the Crisis Receiving Center and to make that center very community-based and community-oriented by having different pieces of that community within that facility. And so that's the other way that we bring in all of those culture nuance pieces when we enter a community is getting to know the stakeholders, getting to know the different pockets and the different communities, and inviting them to work with us as we are supporting their community.
Thank you both for that. Nancy asks, are there any services offered to youth?
As a staff member?
The way I'm reading the question is, you've been talking about the adult system. Do we have any system for youth?
Youth.
Oh, youth, not you. Okay.
Oh,
I
sorry.
misheard that. I'm sorry, Era. We have one adolescent crisis section in Desert Palms area of California that serves as an area for that. I will tell you, when we talk about the future, that's another area of need in the crisis now impacts. And if you go to SAMHSA's National Toolkit, there is a great addendum in the release of the National Toolkit when they talk about that. It's a great article talking about how the infusion of crisis now with adolescent and youth care is so important, and some good guidelines to think about that as you're designing it. Because as one of my friends, Margie Balfour, says, kids are not just little adults. They have their own nuances, and you have to be engaged. Your crisis service have to be engaged even more so with the family, with schools, classes, things like that, when you're talking about inpatient or mobile support going out to sites. And so it takes some differences in level of expertise and supports in the way you do it in the setup. So we do it in a small amount, but it's not a major thing that we're experts in at this point. But there's really not a national fulfilled pathway framework for that yet.
Thank you. Jennifer asks, she says, Georgia's crisis community services as it pertains to transitional housing, Shelter Plus programs, HUD, consists of strangers living together in an apartment setting, which is traumatizing. Are there any safer housing options for patients receiving behavioral health care?
So I can jump into that one. So this kind of goes into that next level, right? The step down, the resources, all of those options. For us, we've seen kind of several different ways. There's short-term respite that's more individual rooms and individual space and all of that, as well as individual apartments and those types of things. Those are residential services that we support as well and are operators of in different states, with the support of our peer support specialists and our staff being able to come in and support individuals who are in need of that extra support. So I will say there are different options and different models that take into account someone's individual personal space and wanting to make sure that they are safe and have that autonomy. To me, that's the similar to, are you comfortable with group therapy, or are you comfortable with individual therapy, or are you comfortable with family therapy? I believe that for every individual person, there needs to be options, so that they can then dictate what is most comfortable for them, because that's how we recover. That's how we ensure that the supports are exactly what we need. So there are different options out there. Yes.
And
Thank you,
as we
Joy.
talk in part 3 about the future, I think one of the things the future is going to involve is I hope a much greater tie-in and connection in crisis service to social determinants,
Mhm.
and how much that impacts crisis. We see that all the time. I mean, how many times, Joy, is as much a social determinant issue as it is anything else when someone comes to our crisis site?
Yeah, it's very hard to separate out social determinants from the individuals that we see. We are addressing that, as well as we are addressing medical, as well as we're addressing substance use, mental health, spiritual. It's all connected with everyone that we see in some form.
Thank you both. We are at time right now. Someone asked about providing resources. I will be putting a link to our virtual booth so that you can go there and find more resources. Wanted to thank you both for that. I've also put a link to our feedback form in the chat box. Please take a few moments to fill that out. It really guides us and the Technical Assistance Center CARE in creating new conferences, new listening sessions, and really putting together resources that the Crisis Continuum of Care needs. So we need to hear from you to keep bringing you these free resources. Please take a few moments to give us your feedback. We will use it to plan future learning opportunities. Thank you again for attending. If you wait just one moment, I'll be putting that link in the chat box.
Come back and see us in part 3.
Yes, in just 30 minutes.